Good afternoon, everyone. Myself, Dr. Nikhil Lanjewar, currently working as Assistant Professor in Department of Respiratory Medicine, GMC Nagpur. Today we are going to discuss about basics of spirometry. Spirometry is a method of assessing lung function by measuring the volume of air the subject is able to expel out from lung after forceful inhalation. In simple word, it is the measure of airflow during inspiration and expiration. Hutchinson is the first person in 1846 who developed a simple water-sealed spirometer, now current form based on Tiffinio and Pinelli. And spirometry is one of the component of pulmonary function test, which also include DLCO, cardiopulmonary exercise test, and ABG. Spirometry is recommended as gold standard for diagnosis of obstructive lung disease, and currently it is based on ATS ERS recommendation for performing spirometry. Indications of spirometry: to diagnose the presence or absence of lung disease in symptomatic patients, those having cough, breathlessness; to quantify the extent of known disease on lung function; to measure the effect of occupational or environmental exposure; and to determine beneficial or negative effect of therapy like bronchodilator or steroids or lung surgery or pulmonary rehabilitation. Also to assess the risk for surgical procedure, for pre-surgical assessment, and for clinical research purpose and for epidemiological purpose involving lung health or disease. This is about indication. Now discuss about contraindication of spirometry. Myocardial infarction within last 1 month, hemoptysis which leads to forced expiratory maneuver may aggravate the underlying condition. Pneumothorax, because spirometry leads to increased positive pressure in pleural cavity, may worsen the pneumothorax. Thoracic, abdominal or cerebral aneurysm, recent eye surgery like cataract, pregnancy, acute disorders like vomiting, nausea and vertigo, conditions that can lead to suboptimal test like patient having chest pain, abdominal or facial pain, stress incontinence, and patient with dementia or confusion. Now prerequisite for spirometry. Before spirometry, patients do not smoke for at least 1 hour before the test, avoid alcohol within 4 hours, avoid large meal within 2 hours. Patient may eat light food or drink plain water. Do not exercise for 2 hours before test. Also avoid vigorous exercise within 30 minutes. Avoid tight clothing, and do not take inhalers like those having salbutamol, levosalbutamol, ipratropium 6 hours before test. Do not take formoterol, salmeterol 12 hours before test, and do not take tiotropium, glycopyrrone 24 hours before test. Now discuss about the procedure of spirometry. First of all, patient should be comfortable, sit up straight, get a good seal around the mouthpiece. Then breathe in and out normally for 2 to 3 times, so that patient able to build up a rapid deep inspiration. Then a rapid inhale maximally without any delay, blow out as hard as fast as possible, that is blast out. Continue the exhale until the patient can't blow out no more. That should be continue at least for 6 seconds in adults and for 3 seconds in children under 10 years. And repeat at least 3 technically acceptable times without cough or air leak or false start. After that, patient has to breathe in maximally, that is full inspiration. This is pre-test, and for post bronchodilation assessment, patient need to give 200 or 400 microgram of salbutamol followed by repeat test after 15 minutes. Repeat the same procedure. Now in spirometry we mainly look for following parameters like force vital capacity. This is amount of air exhaled forcefully after maximum inspiratory effort. FEV1, which is force expiratory volume in first second. The ratio of FEV1 by FVC, and also we look for the FEV1 changes post bronchodilation, which should be minimum 12% or and 200 ml of pre bronchodilation. Also we look for peak expiratory flow, which correlates with the FEV1 in asthma, and force expiratory flow 25 to 75%. these are the cardinal spirometric parameters which help for further assessment of the test. Now, spirometry should be acceptable so that only after that we can interpret it. So, acceptability criteria for FVC maneuver is maximum efforts, which include no cuff or no glottic closure during first second, and no leak or obstruction of mouthpiece. There should be good start of test, back extrapolated volume less than 5% of FVC or 150 ml, which means back extrapolated volume represent the hesitancy of patient. There should be no hesitancy. And tracing shows at least, tracing means graph shows at least 6 seconds of exhalation, and with 3 seconds for children, or an obvious plateau of 2 seconds. No early termination or cutoff, or subject cannot or should not continue to exhale. And reports the highest FVC and FE1 even if they come from separate maneuver. Means it's not both highest value from same maneuver. It may be from different maneuvers. This is about acceptability criteria. Now discuss about the reproducibility criteria, which includes 3 acceptable spirograms have been obtained. Apply the following test. The 2 largest FVC within 150 ml of each other, are the 2 largest FE1 values are 150 ml of each other, and PF values may be variable but should be within 15%. If these criteria are met, the test session may be concluded. Best 2 blows within 5%, or it's mistake, but it's actually 150 ml of each other. Then if the criteria are not met, which we earlier discussed, continue to test until the criteria are met with analysis of additional acceptable spirograms, or total 8 tests have been performed, or patient cannot or should not continue. Save at the minimum 3 best maneuver. Now these are the 2 graphical representation of spirometry. First one is volume time graph, and second one is flow volume loop. The graphical representation is very important for acceptance of the spirometry. Now, interpretation of spirometry. Spirometry should be interpreted only with clinical or radiological correlation. It should not totally based on values of spirometer. There should be matching with patient's clinical and radiological reports. Spirometry is only a diagnostic aid. Spirometry values recorded on different equipments and by different technician may vary considerably, and also it varies with its values predicted depends on age, sex, race, and height. And Indian predicted always 10% below the Caucasian standards. Now the different issues of spirometry, whether the graphical representation is acceptable or not. Now, as earlier we see the graph of flow volume loop and volume time graph. In this graph, this is flow volume loop where the expiration is not continuous, which is probably due to cuffing efforts. So this graph is not acceptable for interpretation. Other abnormal FVCs are like this is volume time curve, which do not curve upward smoothly. So it is also suboptimal effort. Other example like trace does not curve smoothly up to plateau, affects the volume of force vital capacity. There is plateau, but it is not smoothly. It is abrupt plateau, so it is also not acceptable. Other abnormal force vital capacities like this is already discussed with flow volume graph. Now it is a volume time graph where there is irregularity showing cuffing. Cuffing is a common problem while performing spirometry. Other abnormal FVCs are there is a trace is not smooth and upward. Extra breath has affected the volume of FVC. Affected FVC giving false results. This is a graphical representation of extra breath. These are already discussed in previous slides. Now, how to interpret the spirometry? First of all, we look for FE1 by FVC ratio. If it is low, then look for FVC. If FVC values are normal, that is predicted value more than 80%, then probably patient having obstructive disease, and then look for the assessment with the help of bronchodilator reversibility. If FEV1 low and FVC also low, then it is either mixed pathology or with severe obstruction. If FEV1 by FVC values are normal, then look for FVC. If FVC is low, then it is restrictive disease. If FVC is also normal, then it is normal spirometry. Now, for restrictive disease severity is classified based on FVC value. If FVC is predicted FVC values between 80 to 60%, 60 to 80% is mild, 45 to 60% moderate, and in severe cases it is less than 45%. For obstructive abnormality, it is severity based on FEV1 value. For asthma it is different, and for COPD it is different. For asthma, FEV1 value mild in predicted more than 80%, moderate 60 to 80%, and severe less than 60%. And in COPD, FEV1 value of predicted more than 80% is mild, moderate is 50 to 80%, and severe is 30 to 50%, and very severe less than 30%. One more parameter we can describe in spirometry, that is FEF 25 to 75. It is a mid of expiratory curve, which is represent the status of small airways. Though it is highly variable, but we can somewhat diagnose about small airway disease. This is already graphical representation of flow volume curve, and it is volume time curve, and this is flow volume loop in different disease. Let's discuss about causes of various obstructive and restrictive disease. As I mentioned here, obstructive disease include like COPD, bronchial asthma, bronchiolitis, bronchiectasis, cystic fibrosis, acute bronchitis, and alpha-1 antitrypsin deficiency. Restrictive disease like obesity, pregnancy, ascites, interstitial lung disease, kyphoscoliosis, pleural effusion, neuromuscular disorders, diaphragmatic abnormality, lung resection, and congestive cardiac failure. Let's discuss about few cases, how to interpret the spirometry. As we already discussed in previous slides, first of all we will look for FEV1 by FVC ratio. It should be more than 0.7 or more than 80% of predicted. Then we look for FVC and FEV1. So in this graph, mostly we check the values of post bronchodilation. FEV1 by FVC values of less than predicted, that is 70%, and also FVC is normal, but FEV1 is low, and post bronchodilation changes show more than 12% reversibility. So it is likely the bronchial asthma. As history also suggests you, the patient is 31-year male with atopic complaint of dyspnea and wheeze for 12 years. So from this spirometry, we can say patient having bronchial asthma. It is also confirmed with after treatment spirometry, which show all values are more than 80% of predicted. So patient showing good response to the treatment. Second spirometry, a 50-year male, 30-pack-year smoker with complaint of cough, dyspnea, wheeze. First, look for FEV1 by FVC values. It is normally it is considered it should be FEV1 by FVC ratio should be more than 0.7, but in this case it is less than 0.37. It is 0.37. Then look for FVC. FVC is also low, and FEV1 is less than 80%. That is it. In this case, it is 23% of predicted. So it is it indicated very severe obstruction with no reversibility. Post-bronchodilation changes less than 12%, only 11%. So probably patient having very severe obstruction, likely COPD. Let's discuss the third case of a 70-year female with complaint of dry cough, progressive dyspnea, clubbing, bibacillar fine crackles, and exercise desaturation. Then first check for FeV1 by FVC ratio. It is more than 80%, or in term of liter, it is more than 0.7. In this case, it is 0.9 to 1 liter. Then check for FVC. It is less than 80% of predicted. In this case, it is 53%. And having near normal FeV1. So patient likely to have restrictive lung disease. This is the basics of spirometry. Thank you so much.